Detective Canard leads that unit and also chairs this community's Prescription Drug Diversion Task Force. He was also recently selected as the Sheriff's Office Deputy of the Year for his performance in organizing and leading for his role in organizing and leading a pharmaceutical diversion unit with significant inroads towards saving lives. So I want to thank him. We also have PJ Brooks, who's going to speak first. He's the Vice President of Outpatient and Youth Services for First Step of Sarasota. He has more than 22 years of counseling experience and is a licensed mental health counselor with a master's degree in rehabilitative counseling. He is a certified clinical supervisor and has many years of clinical training and experience. And along with substance abuse counselors, PJ regularly provides addictions training to local law enforcement and corrections officers. He's also a statewide trainer for the Florida Association of DUI Programs. So I want to welcome these folks to PJ.
We really looked at that. It was very important for us to, from not just to talk about a medical perspective of what we're dealing with, but also to talk about the side that is being presented in our community with the ultimate outcome, unfortunately, of the overdose deaths and the other unfortunate outcome, the number of drug-exposed births that we're seeing. In fact, it's at a point now in Sarasota County where I've had to assign a position to work with the neonatal ICU to try to engage the parents of the drug-exposed children in the treatment process, because it's a real challenging situation right now. I hate to say it, but it really is a wound-to-tomb situation right now. Okay. That said, I've been in the field 22 years, and I can say without a doubt, and I came into the field right as crack cocaine hit. I mean, it was, and I've been in Sarasota my whole life, been here since I was 2, grew up in this community, went to the schools, came to work my entire life here, and when crack cocaine hit, I watched it decimate communities. But this issue is much more complex than that. But I do need to say this. Addiction, the epidemic of addiction has always been with us. Just recently changed drugs of choice. I don't even know what a crack addict looks like right now. We rarely see them in treatment. In fact, all the old-timer crack addicts that we have that come into care are now using prescription drugs. Okay, that's how prevalent it is. In fact, for the first time ever, our detox unit, in all the years that we've recorded the number of, the reason what the drug of choice was at admission in our detox unit, for the first time ever in 2009, 2010, that fiscal year, opiates have outpaced alcohol. Historically, alcohol runs about 60, sometimes 70%. It is now at 44%, with opiates at 47% of our reasons for admits. So I think that starts to paint a picture. Plus, I forgot to say this afternoon, the age of which our admits are presenting with is getting younger and younger. It used to be that 40-year-old alcoholic, and now it's a 25-year-old opiate addict. Okay, their disease cycle is escalating exponentially. What used to take 5 to 10 years is now happening in a matter of months. Okay, and it really is putting unique strains on what we're trying to deal with. And in many respects, what we're wrestling with as a treatment provider is I can have a client who is sentenced to our programs. About 60% of the clients who come to First Step are sentenced from some court proceeding, has a charge of a possession of a controlled substance, walks in my door with active prescriptions, and I'm at a loss on how to challenge them with that. Because guess what? I'm not a doctor, and I didn't stay at a Holiday Inn Express last night. So I have to rely on that prescribing physician to work with me, to work with that client, to move them away from the medications that they're on. Now, I'm going to say this, and this is one of the most challenging pieces of this, is that we have a mandate in our system to require that if a client is coming to us for treatment, that they have to have a consent for release of information for us to communicate with you physicians who are prescribing. And they'll, by and large, believe it or not, sign those releases. And then we'll send out our information out into the black hole of the world. we rarely get responses back from physicians about what's going on with that patient. And unfortunately, sometimes the response is really this: didn't know they were in treatment, fire him as a patient. Okay? And believe it or not, yes, we believe that a lot of them need to come off those medications, but that's not what we're about. We understand that there are people with a disease of addiction who also have pain issues. And it can be a complex issue, but we need the assistance of that doctor. In fact, what we find is our treatment outcomes, when we're able to communicate with a physician, and it doesn't mean active daily, you don't have to, and I understand everybody has challenges with their time and everything, but when we can have some level of communication with that prescribing physician, our treatment outcomes go through the roof. It really is a dramatic increase in our ability to succeed with managing not only what's going on with that patient in terms of their addiction, but also with their pain management. Because some of the things that often don't get talked about, one of the terms that we need to discuss is the term hyperalgesia. We have a lot of folks who present, you would talk about increased tolerance, but also what starts to happen is that as they're becoming more and more addicted with the opiates, they are presenting also with hyperalgesia, so that they become more and more hypersensitive to their pain when they're coming down. Really what's happening is they're experiencing withdrawal, and that withdrawal actually centers in the area that they think they're in pain. Guess what? Sounds really, so what happens is they present to you, and all their symptomatology seems to be, and again, remember, I'm not a physician, so just take it for what you want from this guy up here. But it's really about that they're really dealing with withdrawal, but it has every indication and appearance of an issue of pain, maybe breakthrough pain, however you want to look at it. Okay. Now, what I think is also very important is that I want you to know we look at three types of patients that present to you if they're in terms of pain management. You have that legitimate pain situation, whether it's acute or chronic, more often than not acute, and you're able to work with them in a pain management way, in a comprehensive way, and the treatment outcomes are successful. Then we have that patient who is not presented addictively yet, but is probably an alcoholic or has some other issue with other medications or not medications, but other drugs, does have an injury, a legitimate injury, presents to you, and that medication that you prescribe in all appropriateness becomes the tipping point to head them down their spiral to addiction, to really escalate the process. Then we have the drug seekers. We have those folks that are coming to you with those fake MRIs, they have all the lingo that they need to say, and they know how to talk to you, and they know how to communicate and say what they need to say. And in fact, they can probably coach you on how you can write your note so that you cover your tail. Okay? And I mean this. We've got some pretty articulate clients that are coming into us. And it really is about drug seeking. In fact, what we see is, and I poll our clients that come into us, and yes, we do have pain clinics, and there are those rogue physicians everywhere. They're the minority in all aspects, and in truth, the biggest area where our clients go to is Hillsborough County. But and they go in droves. You know, they'll go in packs. They'll go up and they'll do the routine. They'll do the route and hit multiple doctors up in Hillsborough County, getting thousands of pills, and I mean thousands of pills. Okay, and then they'll bring them back and they'll eat what they need for their own purposes, and then they'll sell the rest. And what you'll find is most of the folks are getting their pills from friends. Okay, but then they run out. And then they're craving, they're going through withdrawal, they're getting dope sick, and they hit you as a tip, to kind of help them ease through before they're able to get back up to what they need to do. And so what we're talking about here is that we, at least as a treatment provider, not just as First Step, but all of us who are out there, Postal, the private practitioners who are out there who are dealing with addiction, really want you to consider us as part of that, as maybe, the addiction specialty, that you would be referring to, and communicate with us. We have an opportunity to save lives in this community because we're burying people. Okay? The day that I was actually scheduled months ago to do a presentation at ODA, I walk on that campus, and I've met at the door with a faculty with tears in their eyes saying, you can't present today because we just lost a kid. Okay? It doesn't care if you're poor, it doesn't care if you're rich, it's an equal opportunity offender. Now, all of this we can talk about gloom and doom, but we really are faced with an opportunity. And this is our opportunity. We are bringing into light the disease of addiction in a legitimate way rather than as a moral issue. Yes, we do have arrests and we have those things, and I'll tell you right now, law enforcement is our first interventionist. We appreciate what law enforcement does to save lives. Yeah, they may have someone with a charge, but that person's on this earth. But we have an opportunity to get the entire community rallied, which you all are members, rallied around the fact that we want to see some changes. We want to see this stop. And what that means is it's not just, okay, we got to make all this bad stuff, make those bad doctors go, well, you know what, there's always going to be bad things happen. We need to be looking at what do we got to do to develop the resources and the comprehensive network to treat and work with those folks, just like you would if you were treating hypertension, asthma, and diabetes. Guess what? Those are chronic, incurable, but treatable diseases as well. And if I were to say to a person with insulin and say, well, here's your 10 shots, that's all you get, come back to me in January, it doesn't work that way. But that's kind of how we measure our addiction in many respects. We don't really give it the value that we need. So I'm imploring your support and involvement as we look at what we need to do with addiction. All right, with that said, and I need to tell you, this is exciting for me, not just because of you all here, but I hope you understand the gravity of the comprehensive approach that's happening here in this community. We have law enforcement working hand in hand with public health, working hand with the treatment community, now working hand in hand with the physicians community in a way that we're going to tighten that net so that less and less people can slip through. And I think that's exciting because you know what, that's not happening in other places. I'm involved at the statewide level with the Florida Alcohol and Drug Abuse Association. We are the leaders in what's happening. I know it may not feel like it when you have someone you care about die, or a baby be born to a family member that's in an overdose or in withdrawal. But really we do, we are really the leaders, and I hope you rally with that and move forward. So thank you for the time tonight.
My name's Don Canard, and I'm a detective at the Sarasota County Sheriff's Office. I think it's important to note that when Sheriff Knight took over as sheriff, he realized that prescription drug abuse was a tremendous problem in law enforcement. It was driving our crime. Our overdose deaths were, as we've talked about, we traditionally in law enforcement take sometimes a narrow approach in just enforcement. Sheriff realized that we needed to focus our efforts in a diverse manner, and that's why he created this unit. Talk a little bit about the history. We talked about today, about a week ago, the federal government coming in and mandating and regulating, and the ground is being laid for more regulation in the dispensing of controlled substances. So we go back to some of the first legislation in 1914, the Harrison Act, federal government legislation that how do we typically in government enforce laws? We tax. That's one of the first ways that we govern morality with taxes. So in this case, the 1914, you see the Harrison Act was actually enacted in 1915. And after we create laws, what happens? Someone breaks a law, or laws are challenged, and you start to see your first court cases come to light involving doctors and regulation and prescriptions. This case of Doremus was a 1919 case. Basically, the question was, does the federal government have the right to regulate prescribing medicine by physicians? And the answer is yes from this case. And Doremus was a physician who basically was supplying a patient heroin that really had no medical injury, was just merely the way that the statute, or the way that the case law read was a common dope fiend. And he supported that habit and was prosecuted for doing so. Next case, again, later that same year, a Webb versus U.S. Webb was a physician. There had an associate who was a pharmacist in close proximity to that practice. They both basically agreed that I'm going to prescribe heroin to some patients that are drug addicts, and I'm going to refer them to your pharmacy, and they're going to come and we're both going to profit from this. This doesn't sound very different from modern day, and that's why I'm trying to point that out. This is a problem. It's been a problem for quite some time. Just recently, we've seen how things have escalated very rapidly. In the 1970s, you see tighter regulations of your pharmaceutical companies, and also the creation of the five different schedules of drugs that we commonly know today. What type of trends of pharmaceutical diversion do we have in Southwest Florida? Doctor shopping, prescription fraud, illegitimate or overprescribing physicians, and overdose deaths. And we'll talk about those. First of all, what is doctor shopping? And the definition's there. Essentially, it is to withhold information from a practitioner with whom you seek to obtain a controlled substance, and while seeing another practitioner within the same 30-day period. The key terms in there are obtaining medications, controlled medications of like therapeutic use. Prescription fraud would be to acquire, obtain, or to attempt to acquire, obtain possession of controlled substances by misrepresentation, fraud, forgery, deception, or subterfuge. Both of these crimes are third-degree felonies in Florida, punishable by 1 year to 5 years in prison. So how much money is there in doctor shopping? Why is this a problem? PJ talked about people traveling around the state, which is extremely common. Why is this such a problem? Well, let's talk about the money. For an office visit, we'll say $250. That may be high. I'm sure there's a lot of folks in here not getting $250 per office visit, but in some areas that is a common practice. So if you were to go and obtain a prescription, once you've paid your $250 for your office visit, $180, and what is it, $270 there with, sorry, the tree's in my way there. Say $270 for your prescription. We'll use for this example, say a 30 milligram oxycodone product. So spending about $520 for this. When you factor in the street value of these pills being approximately $15 to $30 per pill, maybe 50 cents to $1 per milligram, that's going to add up to about $2,700 minus your initial outlay of $520, so $2,180 that you're going to generate from one prescription. It's very uncommon in the pain management diversion game to obtain only one prescription. It's usually multiples, 2, 3. So if you take these numbers and you look at a 10-person organized ring, which is not uncommon, they're going to generate from attending one doctor to $21,800. You're going to go to 4 doctors. We're going to work 4 days a month, and we're going to generate about $87,200 over a 12-month period. We're looking at over $1 million between 10 persons, $100,000 tax-free. And the best part, you're still able to feed your habit and your drug addiction. So you can make a living and sustain your habit. One reason why we're having so many problems. From the show of hands, the majority of the folks in the room are medical doctors, so why would someone risk losing their DEA license, going to prison, by inappropriately prescribing in a criminal act? I think that's a legitimate question, and this slide may help some understand that. You take those same numbers of the $250 a month, $3,000 for a year per patient, times 300 patients, it's 900,000, 600 patients, 1.8 million, 1,200 patients, $3.6 million. If you added the numbers of the dispensing practitioners and followed those same numbers there, it's just merely a 50 cent per profit per pill. You're still looking at additional 300, 600, and 1.2 million that could be generated with those numbers. There's a lot of money in this. It's a big business, and it's very difficult to pursue that from a criminal angle. Do we have a drug problem? Some of the statistics here I'll just breeze through. They're in your guide there on your SafeRx. The number that you hear, 7 Floridians a day dying from prescription drug abuse, is in some circles conservative. From 2003 to 2009, we've had 102% increase in drug deaths related to prescription drug abuse. 79% of all drug-related deaths in 2009 were related to prescription drug abuse. 86% of the drugs identified as a cause of death from our local 12th district medical examiner were prescription drug deaths. And in 2008, the unintentional poisoning rate among 20 to 24-year-olds was 4 times greater than the state average. Some other consequences, the Department of Children and Family Services report that about 67% of their referrals come related to prescription drug abuse. And the numbers, as we spoke earlier, from newborn babies going through withdrawal have increased drastically. How we address this from the Sheriff's Office and the Pharmaceutical Diversion Investigative Unit is to kind of take a 3-prong approach from enforcement, prevention, and education, and try to coordinate all those worlds together. We have a community partnership group at the Sheriff's Office that includes local physicians, local pharmacists, the medical examiner, advocacy groups, groups like First Step and Coastal, the rehabilitation organizations in town, the health department, and the National Drug Diversion Associated investigators. The cycle of information that we try to glean, once pharmacists or doctors report information to us or suspicious activity, we attempt to do what we can to investigate that information. Some information develops in intelligence, some information develops into criminal investigations, which we can pursue. But ultimately, we try to get that information back out, and again, to pharmacies and to doctors to let folks know what's taking place. What are we doing at the Sheriff's Office to combat this problem? One of our initiatives that we're very proud of is our narcotics overdose prevention education high school presentations. These are very somber presentations that relate to prescription drug abuse overdoses. Our Operation Medicine Cabinet, permanent locations at our north office and our south office, the small brochures you have there that have the where you can index your pills and count pills. You'll have both sides of those have our locations where you can refer your patients to dispose of. And I think the doctor made an excellent point by letting your patients know if you're not taking all of your medication, don't let it sit in your cabinet for years and years. There's too many bad things that can happen with that. Please refer them to use that proper disposal site. We're currently investigating licensed medical professionals here in Sarasota County and throughout the state. We work with state, local, and federal law enforcement as well as regulatory entities. We conduct presentations such as this for local pharmacies, doctors, civic groups, Department of Corrections, Department of Family Services, to try to educate as many as we can to these problems. We've also requested that local pharmacies voluntarily submit to photo identification for controlled substances in patients that they're unaware of or are new patients. Our SafeRx campaign, which we're here tonight. Drug abuse education and prevention forums. Ourselves, the Sheriff's Office, Coastal, and First Step did our initial presentation at Riverview High School last year. We had about 250 people show up. We're really hoping to have stronger support this year and to hope that that grows and to educate the community at large as much as we're educating our medical professionals tonight. And our jail recovery pod, this is something that the Sheriff's very proud of. I think many practitioners are concerned about reporting someone for a diversion-related crime, concerned that that person is going to go to jail and that's going to be detrimental to their future. As PJ's pointed out, law enforcement, from my experience and going to presentations, it's rare that I go to a public presentation I don't have someone tell me at the end, "Thank you, you guys arrested me and you saved my life." It was the one point where I realized that I had to do something about my addiction. And the jail pod recovery effort there allows persons who are incarcerated to begin their recovery process while being incarcerated. What can medical professionals do to prevent prescription drug abuse? We've talked about some negative things, we'll talk about some positive things to try to prevent these crimes from happening. To establish a legal protocol to discharge, refer, and/or report patients who are suspected of diverting controlled substances. Consider the use of a detailed controlled substance agreement. The agreements, the better the language, my advice would be to seek some legal counsel on that, but to make them very clear cut. The disclosure issues can sometimes be very sticky, and people are very conservative when it comes to that. To have that agreement very black and white when it comes to that, so you feel comfortable when the time is appropriate that you may make that referral to law enforcement if you feel necessary. And to maintain strict control of your prescriptions. Many times we go to offices and see that there are controlled substances within the office setting that really aren't as secure as we would like them to be. Prescription pads, I know this is something that as medical professionals you hear all the time, but week in, week out, when we're in practices, we still see prescriptions laying around. The lack of attention to that is still a problem. And for those physicians who have had their prescriptions or their DEA numbers stolen and had to deal with us calling you and pharmacists, it's a very uncomfortable, time-consuming issue. Consider increasing the security level of your prescriptions. There's some really neat technologies out there for a relatively economical price. You can upgrade your security paper there for your prescriptions. Verification of medical records and MRIs and the pharmacy and doctor level. Anything that's really in that medical file I've seen duplicated fraudulently. If I'm attempting to doctor shop, I want to bring records that are the highest end records that I can that are gonna substantiate you being able to write me the strongest medication that you can write me as fast as you can write it for me. So I may want to embellish my records utilizing someone else. It's very common in the industry to see that. And if and when we do have a prescription drug monitoring program, please learn that system, know that system, make that a part of your universal precautions to prevent and protect your practice, to prevent diversion and protect your practice. We all know that street drug users can be dangerous and unpredictable. There's this misconception that because it's a legal drug, that persons addicted to that are not going to be as dangerous as you would consider a street drug user, and it is untrue. It is just like anything else. I think PJ made the analogy at one time in speaking with somebody in recovery that the person said, it feels like someone's holding my head underwater. So I ask you the question, if someone was holding your head underwater, what would you do? I think the answer is whatever I had to do. People, when you're going through that withdrawal, that fear, that anxiety can be the most dangerous individual that you'll ever want to see. So please be concerned of that and be careful in your practices. Thank you for your time.
I want to thank you all for being here. We do have a few minutes left for questions. So I want to invite Dr. Zakharoff back up. And if you have a question, feel free.
Does anyone here know the status of the drug database that our governor doesn't really like very much? Do you know what the status of that is?
Her question is about the status of the prescription drug monitoring database.
At this point, the database is moving forward. It has not been, in fact, the governor backpedaled a bit and has come out in his recent statements to Congress. He did state that he was now supporting the effort of the database. So I believe it's going to be operational. Again, we've been hearing this for a while. Those of us who wait with bated breath, and again, mind you, it only works as well as you are willing to use it. Okay, if there can be all kinds of data in there, and if you're not looking at it to find out what's going on, it's useless. So it's really important that you do get engaged with it once it's available.
And the latest from the Florida Surgeon General is that it will be operational by August, late August. But we've heard things like that before, so something to keep in mind. Any other questions?
the stuff presented tonight is very good, the lecture in theory, but in practicality, a lot of it doesn't work. A perfect example, I used to soak tests all the time, but the patients lie when they answer it. So what, you can do whatever you said in theory, it's great, but in practice, pill counting, they lie. They bring pills if they know they have to bring pills. If they're short and they're taking too many, they borrow from their friends. The people who are going to do the wrong things are like professionals. They find a way to get around whatever we try to do. In theory, it is great, but in practice, it doesn't work.
Well, in response to that, it doesn't work if we're working in an isolated situation. I think that's what I mean by that is that if we're all working together, if you're suspecting somebody's, I think you're going to have a good feel for who's going to be coming at you that is at risk or presenting that is suspected of diverting medications. And in that regard, then the steps would be, in my opinion, not as a doctor, but as a treatment provider, is to engage with your treatment community and or those resources so that you can develop that connection and that conduit to work between the two. No, it's not perfect, and we're not going to figure this all out. But again, it's about making the holes in that net smaller.
I think a lot of time has been spent talking about opiate analgesics because of the deaths associated with it, but there's a lot of morbidity and mortality associated with a lot of the amphetamines that are being overprescribed for ADHD and ADD, and everybody's got that shit now, So are they going to be making steps and inroads into controlling those docs that are overdiagnosing and overprescribing the amphetamines and benzos and other things?
The reality of it is that there actually are plans in place for a lot of those medications, but since they're in place and they don't really affect us at a clinical level, we don't even know. With stimulants, if you were going to ask me to bet, I would bet that there will be a REMS ahead for stimulants. The reason that it hasn't happened yet is because people don't die from them as much. Remember what I said. The FDA, Washington, D.C., all of the discussion that took place last week is because the new definition of opioid risk is unintended deaths. If people were dying from these medications, the answer would be clearly yes. But since opioid analgesics have now surpassed cocaine and heroin in terms of deaths, that's why they're getting all of the spotlight. If this didn't involve pain management, we wouldn't be here tonight. It would be something else. If it was beta blocker, this room would be filled with cardiologists. It just happens to be the fact that 1 out of every 2 patients seeks medical attention at a primary care level for some pain-related complaint, and it draws us in.
One more question?
Do you have any ideas on why this county is the one that stands out as the worst area, what we're talking about?
We're one of the worst.
Let me just repeat the question so that everyone can hear. He's asking why Sarasota County is, in this region, considered one of the worst counties with the biggest problem.
Actually, what you could do is if you were to go up to Hillsborough County, get on I-75, go north to the Turnpike, take the Turnpike east to I-95, go down I-95 to Alligator Alley, cut across to Collier, up through Lee, back up through Sarasota, Manatee, and into Hillsborough, and then empty the middle. That would be the donut of death. And those are the major counties with the highest rate of overdose deaths related to opiates. And actually, you could take those middle counties, those rural counties, and paint them with crystal meth, and it's kind of like a big donut with a crystal meth center. And it's real. And in terms of the benzodiazepines, it actually follows the same path. But mind you, we're not seeing people dying from one singular drug. It is an absolute clear path that it's a combination of medications, and there's actually what we see the cocktail is being described as this: opiates, benzos, and so on. That's what we see coming into our doors. Okay, and then they throw in alcohol and the synergistic effect, they potentiate each other. So we got the 1 + 1 doesn't equal 2, it equals 5 and 10, and then these accidental overdoses are occurring. So we are one of the major counties, and part of it, in my opinion, is that we have a lot of resources here. You know, we have a higher income level, and people have access to some money, and then we have the easy access through Hillsborough County. Hillsborough County is huge. Broward and Hillsborough County are the top 2 counties in terms of this process. So,
If you peel away the illegal activity by healthcare providers in the state of Florida, it actually doesn't look that different than a lot of the other states. There were a lot of dark blue areas on that map, and for the sake of time, I didn't refer to an article that I have on my smartphone, but it was in the New York Times 6 days ago about a town in Ohio where 1 out of every 10 babies is born addicted to narcotics. Now, that's exactly what we said here tonight. So it's a matter of the 2 problems combined that sort of magnify things. But if you were going to peel that away, one of my favorite lines as a doctor is, we're all the same animal. And the problem exists all over the country. And this is why Washington has focused like a laser beam on this issue. The issue around the pill mills is another issue. It's a totally separate issue. But if 42% of the prescriptions for opioids are being written by primary care clinicians, and everybody's aware of it, and people are dying as a result of these prescriptions, something's got to give. And what's going to give ultimately is that DE registration is going to be tied to educational initiatives, just like this one tonight. So save your certificates, because you will need them. The legislation has already been introduced, and that means that nobody will be able to ever write a narcotic prescription for someone unless they go through the education and supply the proof to renew their DEA license. A couple of states have taken a different approach. California was the first state to require that a certain percentage of your continuing education credits be devoted to pain management. Massachusetts just enacted that January 1 of this year. So there's a change in the wind. Patients are going to lie, but I don't think every patient lies.
Professional opinion would tend to be unethical. That's something that you can report to the Department of Health right from their website. You can log on to Department of Health's medical quality assurance and make that complaint. And the fact that I believe if more practitioners did that, practitioner to practitioner, I think that the Department of Health would take that with greater weight, and that those investigations would mean more in the fact that someone is willing to stand up and say, I'm a professional and I'm looking at what's going on here, and with this patient who was, had track marks up and down their arms, could not stand up. I refused to serve them. I refused to provide the prescription because I was unable to speak to them because they were slurring so badly. All I think those are appropriate steps.
Our speakers have mentioned that this being a partnership approach to address this problem, and you are part of that partnership. And so we are really encouraged by the participation at these events. So thank you very much. I do want to point out that we have these safe disposal flyers at the back table for pickup. You can take a snack and bring them to your office or pharmacy. And again, I want to thank our sponsor, MetLife, Diane and Brooke, thanks so much for your help coordinating. And also thank you to SMH for providing the CME credits.